Osstem did not stay and enjoy the present success, but we entered the field of digital dentistry and launched OneGuide. OneGuide draws the optimal surgical condition based on the patient's scan data and then guides the dentist through the operation guide to carry out the implant surgery safely and accurately.
After using the OneGuide system, I was much less burdened with implant surgery. The kit is safe and easy to use. I am much more confident with the simplicity of the process.
Using the OneGuide allows me to place my implant and to temporate the same visit, which increases patient satisfaction.
If you do not have OneGuide, you can use SmartGuide. The SmartGuide allows you to precisely position the implant through a surgical template, allowing you to complete the procedure quickly without CT scanning. Development of technology leading the market. Products with good qualities. Company providing high-quality clinical training. Osstem will continue to innovate to provide better technology and quality clinical training. Osstem will listen sincerely to your voice and will do our best to help dentists with treatment. The remarkable growth of Osstem owes much to the trust of customers who respond to our constant efforts to satisfy customers. We will continue to grow with our customers by providing superior solutions that satisfy both dentists and patients. We aim to become #1 choice of implant supplies among American dentists.
Contribute to the improvement of human health by helping dentists with better care. This is the reason why Osstem was founded. And it is the motivation behind our quest to grow into a global implant company. Osstem Implant, a company that helps dentists with better care. What is Osstem's better care? Firstly, it means helping dentists provide successful care using innovative materials and equipment essential for dental care. Second, providing higher-level clinical education to improve dentist clinical knowledge. Osstem is extremely passionate about R&D for successful dental care. Every year, we invest 7% of our sales revenue into R&D, and we have more than 400 expert researchers who devote themselves to developing innovative technologies and products. As a result, Osstem has the highest level of implant design and surface technology in the world, and boasts a wider range of implant products than any other company. Since 2017, we have surpassed the world's leading companies and have been recognized as the #1 implant selling company in the world with excellent quality. As a digital dentistry leader, Osstem has established a full lineup of digital dentistry products, such as dental materials, dental equipment, dental services, software, and dental operations software, leading the digitalization of all aspects of dental care from diagnosis to completion of treatment. Osstem also offers premium clinical education master course to increase the rate of independent implantation and help dentists provide better care. Osstem's master course, which is packed with clinical knowledge, has been praised for having the best instructors and for its systematic approach to education, encompassing theory and practical application. It has been recognized for accomplishing new standards for clinical education. As a result of expanding the training overseas, there are over 80,000 domestic and international dentists who have completed Osstem's clinical training and are contributing to the clinical development of dentists around the world.
똑똑한 사람은 혼자 부자가 되는 사람이고 위대한 사람은 여러 사람을 부유하게 만드는 사람이라 합니다. 오스템은 이러한 철학을 근간으로 위대한 기업이 되고자 치과 의사의 더 좋은 진로를 도와줌으로써 인류 건강 증진에 이바지하고자 설립되었습니다. 오스템의 경영 철학은 설립 목적을 근간으로 첫째, 고객의 성공을 도와줌으로써 성공한다와 둘째, 좋은 것은 더 좋은 것의 적이다로 정립되었습니다. 오스템은 치과 의사의 성공을 돕기 위해 끊임없이 고민하고 노력하고 있으며 보다 많은 치과 의사의 더 좋은 진로를 돕기 위해 보다 큰 글로벌 기업으로 성장하는 꿈을 꾸며 도전하고 있습니다. 그래서 치과 의사들이 오스템과 함께하면 더 좋은 진로가 보다 쉽게 이루어지고 부와 명예도 얻게 될 것입니다. 앞으로도 오스템은 인류 건강 증진에 크게 기여하는 위대한 기업으로 성장할 것이며 임직원 또한 위대한 사람이 되고자 지속적으로 최선의 노력을 다할 것입니다.
Osstem Implant helps dentists with better care and has grown into the implant company that is used most by dentists worldwide. We will not rest on current achievements and will continue on our quest until the day that we are the world's #1 implant company by the year 2023. Leading the future of the global dental industry. Osstem Implant.
Hello everyone, I am Dr. Kyung-won Kim. I will serving as a chairperson for this Osstem meeting online program. I'm so sorry about that slight delay due to the technical problems of the internet connection. Before we start, it's great honor for me to be hosting the first Osstem meeting online program for this for the second half of 2020. On behalf of Osstem Implants, sincerely thank all of you for your support and for attending Osstem meeting online program throughout, despite of the such a worldwide COVID-19 pandemic circumstance. I think the best way to reward our viewers' enthusiasm to deliver even better, more advanced Osstem meeting online program during the second half of 2020. Today's Osstem meeting online session will feature on exciting live surgery and as well as lectures from Korea and Turkey connected via video conference technology in real time. The first lecture will be held by Dr. Yongjin Kim. Dr. Kim talk about a full mouth implant placement and immediate loading with OneGuide system. His lecture will be immediately followed by a live surgery. So please stay tuned into this session until the end. Well then, please let me invite Dr. Yongjin Kim.
Hello, I'm Dr. Yongjin Kim from Korea. I'm so glad to meet Turkish dentists through this online meeting. Also, I'm so honored to have opportunity to perform a live surgery. Today, I placed 8 implants with Osstem digital guided surgery system called OneGuide. Before I start, I'll briefly explain my surgery plan. This patient is a 56 years old male patient with no significant medical history. These are pre-op photos. Today, I place implant in mandible right after extraction. As I said, I will use Osstem OneGuide system. How can you place implant well in these challenging situations, including fully edentulous patient or multiple implant placement? Well-placed implant means the implant with ideal position and angulation for final prosthesis. So I think digital guide surgery system can be a good solution to overcome these situations. These are my main reasons why I prefer digital guided surgery system to overcome these challenging situations. The first reason is virtual preoperative planning will be possible. Through implant planning program, we can get blueprint of final prosthesis. We can expect the size and shape of final prosthesis, and then based on that planned final prosthesis, we can make good implant placement plan. The second is to decrease the invasiveness. As we all know, by using digital guided surgery system, we can do planless surgery. Planless surgery was a blind technique, but in this day, if we can make good implant placement plan on the program, and also if we can transfer the planned implant position to our patient mouth exactly, we don't need to open the plan widely. So I think in this day, planless surgery is not a blind surgery, only if we can use good digital guide surgery system. So I will use digital guide surgery system for today live surgery. The third reason is ideal implant positioning will be possible for final prosthesis. Current trend of implant placement is restoration-driven implant placement. So with the implant planning program, we can make good prosthesis design, and then we can make good implant placement plan, just like this case. As you all know, malpositioned implant will cause several problems, maintenance problem or mechanical complication. Final reason is for easy provisional restoration delivery for immediate loading. In this case, as shown in this slide, the left molar was extruded. So occlusal plane was collapsed. So to make ideal occlusal plane, we need provisional restoration. And also to adapt my patient to this newly established occlusal plane, we need provisional restoration. So immediate loading should be done. So I designed one-piece type provisional restoration, and then right after implant placement, I will deliver this one-piece type provisional restoration. So to use OneGuide system, we should combine CBCT image and surface scanning data. Merging should be done. And then after merging, prosthetic design was done on the program, and then this is implant placement plan. Left side and anterior side and molar area. So I place implant like this. So during drilling, to prevent the surgical guide tilting, I will fixate my surgical guide template with anchor pins to prevent this kind of distal tilting of surgical template. So with 3 anchor pins, I will fixate OneGuide template. As shown in this template design, you can find out 3 screw access holes. So to summarize, right after extracting the lower teeth except left 2 premolars, 5 implants will be placed with OneGuide surgical template in the mandible. Left lower premolars will be left to support OneGuide template. After that, extraction of left lower premolars will be done, and then vertical reduction osteotomy will be done in left side in order to secure sufficient vertical dimension for final prosthesis. Finally, 3 more implants will be placed in the left side, first premolar and first and second premolars. For the left molar implants, drilling will be done with OneGuide template, but implants will be placed after vertical reduction osteotomy. After suturing, prefabricated provisional restoration will be connected to the transfer abutment for immediate loading. And this is my live surgery plan, and I will start my live surgery. Thank you. So I start extraction first.
Yeah, now the Dr. Kim is start the live surgery, and first of all the extraction of the tooth, and except the left side premolar.
아프세요?
Dr. Kim, can you hear me?
Yeah.
Yes.
As I said, these two left lower premolars will be left to support surgical template, except
Yeah, Dr.
this.
Kim is now the extraction of the teeth, except the left two premolars. The two premolars remaining for the support of the OneGuide system and the surgical templates. Yeah, Dr. Kim did all the extraction teeth. And maybe the patient has a slightly painful, so we had more local anesthetics.
so I will position right template. 네. Fixate this OneGuide template with anchor pins. So drilling for anchor pin will be done. 살짝 다물어 보실까요?
Yeah, Dr. Kim has the positioning of the OneGuide templates as a support from the left side, the remaining teeth, two premolars. And for the position of the template, surgical templates, the anchor drilling for the anchor pin placement.
지금 많이 아프세요? 많이 아프세요? 괜찮으세요?
The patient has a slightly painful, so but no problems.
살짝 다물어 보시고. 이제
Yeah, Dr. Kim is drilling for the anchor pins for the fixation of the surgical templates of the pre-planned the exact positioning, and with the remaining premolars of the left side of the mandible.
눌러줘. 눌렀어?
So and now is application of the anchor pins for the fixation of the surgical templates.
자, 파이널 앵커 핀. 살짝 다물어 보시고요. 좀 더 살짝 물어보세요. 이해해 보세요. 조금만 더.
Now the right side, the application of the anchor screw for the fixation of the surgical templates. The pre-planned the exact correct position. Application of the anchor screw to right side.
오케이. 픽세이션 왔어.
Yeah, and about 80% the fixate of the anchor screw, and after then check the position of the surgical templates, and he tried to the final screwing for the fixation. And after then, right side for the anchor screw, one more.
Yeah, the fitting positioning of surgical template is quite good. By checking the gap between the inner surface of template and the remaining teeth, we can check the quality of positioning.
Yes. Yeah. Dr. Kim is verified the exact position of the surgical templates, such as from our surgical planning.
Then I will start the drilling.
Yeah, and the fixation of the surgical templates with the anchor pins, and after then he will start the OneGuide drill for the drilling.
Yeah, this is the initial drilling. 아, 크게요.
Initial drilling
The
of
left side, I place 4.0 by 10.
of the canine area.
Left canine. This is the initial drill. 괜찮으세요?
This is the OneGuide drill for the initial drill. Left side canine
앞세요.
and right
아프세요?
side.
많이 아프세요?
마취 더 해드릴게요.
Yeah, the patient has a slight painful, so we tried the more anesthetics for the patient comfort.
해보실게요.
I think that the patient has multiple extraction and it's slightly painful. And the drilling, initial drilling of the right side.
Right side, initial drilling. 조금만 더 크게요.
And the right side, the premolar area.
The full depth drilling of initial drill is impossible. So in this situation, we should use flattening drill.
Yeah, because of the maybe the remaining alveolar ridge is slightly inclined. At the time, usually sometimes the initial drill is cannot full length. After that,
치세요, 아프세요?
he tried to the flattening drill,
많이 아파요.
the flattening of the alveolar ridge.
마취 더 해드릴게요.
Yeah,
After flattening, I will use initial drill again.
Yes.
initial drill 어딨어?
yeah, Dr. Kim tried to the flattening drill for the flattening of the sloughed alveolar ridge. After then, try to
조금만 더 크게요.
again the initial drill of the full length. Usually, the OneGuide surgery, initial drilling full length is very important because after the subsequent following drills, two-point contact is very important. So this is also initial drill for the right molar area.
Here, in the first molar area on right side, I place 4.5 diameter implant. So flattening.
Yeah, so the flattening drill for the right molar area.
In the second molar area, I will place 5.0 diameter implant. So wide hole was fabricated. So this is the initial drill for wide hole.
Wide hole, yeah. Yeah, usually the OneGuide template, surgical template has two kinds of drill hole size. And for the fixture, diameter is 5.0. At the time, it is the wide hole.
Yeah, this is a flattening drill for wide hole. To secure ideal biology with this, I planned deep implant placement. So highly positioned crestal cortical bone should be grinded.
Yeah, Dr. Kim said he wanted to the more deep position of the implants. So he grind and flattening of the sharp edge of the overlying the alveolar ridge.
아프세요? 아프세요? 추리세요?
Yeah, the patient is slightly painful, so for the patient comfort, and we will do the more local anesthetics.
그리고 오른쪽으로요.
자, now the initial drilling for the left molar areas.
In the left molar area, we placed 5.0 diameter implant. So wide hole was fabricated. So initial drilling was done through all drilling sites.
Yeah, Dr. Kim did all the initial drilling of the whole, all the implant position areas. And usually the OneGuide template has two kinds of size of the drill holes. And up to the 4.5 fixtures is a small diameter of the wide hole, drill hole. And for the 5.0 fixtures is wide the holes of the OneGuide template.
This is OneGuide drill, F3.5 OneGuide drill. Length is 10. Because I placed 10 length implant.
Yeah, Dr. Kim has the OneGuide drill. The length is 10 millimeters. Initial drill for the
up and down motion. 이거 오른쪽으로 잘하고 계시고 마치 필요하시면 더 해주세요.
Dr. Kim has the more the up and down motions for the preventing of the thermal damage of the drill holes. This is the OneGuide drill. Usually after the initial drill and after then OneGuide drill has a two-point contact concept for the stable the drilling and the exact good position of the drilling positions.
And then 4.0 by 10 in the left canine.
Left canine is
in the lower mandible, the bone quality is quite good. So normal drilling sequence will be done. Yeah, so this is a 4.0 for 4.0 diameter implant placement. Right side canine, I place 3.5. So final drilling is done.
Yeah, Dr. Kim said the left side is the 4.0 implant planned, but right side is right canine is 3.3, 3.5. So already the final drill.
Yeah, in this last post premolar I place 4.5. So this is a 4.5 OneGuide drill. Length is 10.
Yeah. The right premolar area is the fixture planned for the 4.5 diameter of the implant. So the final drill is also nominated drill is a 4.5 OneGuide drill.
In the molar area, 8.5 length implant will be placed. So this is 8.5. The diameter F3.5. Okay. And then this is F4.5 by 8.5.
Yeah, for the right molar area is drill length is 8.5 length of the OneGuide drill, and for the wide implant, so the 5.0 fixtures.
And here, this is second molar area 5.0
Yeah.
diameter. So the length will be 7.
The second molar is the length is 7 millimeter and the diameter is 5.0. It means the wide hole of the OneGuide template. Yeah, Dr. Kim has drilling motion is up and down because of the further prevent of the thermal damage of the drill holes.
보시고요. 아프세요? 아프세요? 같이 더 줘. 조금만 더 크게.
Final drilling for the right.
This is 5.0. Length is 7.
The final drill for the
느낌을 드실 수 있으세요.
right second molar areas. The final drill has the diameter is 5.0 and the length is 7 millimeter length of the OneGuide drill.
The right side and anterior side final drilling was done. I moved to left side.
Yeah, Dr. Kim already drilled on the right side OneGuide drills, and to move to the left side molar areas. Dr. Kim did the first molar area of the OneGuide drill.
네, 잘 도와주고 계세요. As I said, I will place two left molar implant after vertical reduction, but to place implant in ideal position, I will do drilling with OneGuide template.
Yeah, Dr. Kim said that the left side is bone reduction is planned. So the OneGuide drill is only the exact position of the drilling points, drilling locations. Already he mentioned the left side is inter-arch distance is very low because of the lower teeth is so he planned the reduction of the alveolar ridge of the left side for the intermaxillary distance for the final processes.
Now I place hand 왼쪽에 다 했을.
Yeah, Dr. Kim already drilled all the drill holes with the OneGuide template.
아니 33번. Yeah, this is 4.0 by 10 in the left canine.
Yeah, placement of the implants of the left canine area is the diameter is 4.0 and the length is 10 millimeter, and with the OneGuide fixture driver.
3번. 빨리 줘. 다음에 4번 줘. In the right side, I place 3.5 by 10. This is a 3.5.
And can place the right canine area. Right canine is 3.5 fixed diameter of the fixture of the length is 10 millimeters.
So I will do depth control. Accurate implant placement. So this previously used no-mount driver can be left to support the template.
Yes. And with the final position of the drilling the implants and the fixture, and with the hand wrench and the exact position.
And was done. Okay, depth control was done.
Yeah. Depth control with the yellow mark of the OneGuide fixture driver is exact position of the fixtures of the left canine area, and the right canine also with the hand wrench for the final position of the fixture. Pre-planned the exact position. He placed the implants with the arrangement of the yellow mark with the template, the holes.
Depth control and next position was done.
So he did the depth control of the fixture and the exact position of the hexa positioning for the temporary prosthesis.
In the first premolar area, I will place 4.5 by 10.
And the first molar area, premolar area is 4.5, the length is 10, and installation of the implants.
And then, 아니, 픽처 들어가겠어. I will do depth control and hex positioning.
Yes, and the depth control with the hand wrench, and you can see the left mark of the fixture driver, and we have the exact positioning of the fixture.
Okay. Hex positioning and depth control was done.
Yes. Usually the yellow mark is arranged to the correct position of the implants, and the hexa positioning and the depth control.
Okay, I will place the implant in the first molar.
Yeah, now is the first molar, right side first molar.
이어폰 빠져. Yeah, this is a 4.5 by 8.5. 거기 왼쪽으로요. 네.
This is also 4.5 implants. The length is 8.5, and the motor driven is about 80% of the installation of the implant. After that, hand wrench is for the exact positioning of the implant with the depth control, and the hexa positioning for the pre-planned the exact position of the implant. Hand wrench.
Okay.
Yeah, primary stability is very good.
Yeah, hex positioning and depth control was done. And then in the second molar area, I place 5.0 by 7.
The right side, the second molar area is the point, the implant diameter is 5.0 and the length is 7 millimeters. And the engine driven about 70 or 80% of the fixture placement. After then, hand wrench for the final positioning, and with the hexa control, with the depth control of the fixture placement.
Yeah, in the second molar area, the initial insertion torque is too high, so I will do more drilling.
Yes. Dr. Kim said the second molar area is the bone quality is too high, and the primary stability is too high, so the removal of the implants, after then the more widening of the drill hole for the final initial stability. Maybe in case of the too high torque of the implants placements, at the time though you can remove the fixture, after then widening of the drill holes for the optimal initial stability.
This is F5.5 drill for oversized drilling.
Yes, he planned the diameter is 5.0 fixtures, but now is a drilling of the with the 5.5 drilling. So the oversized drilling one size upgrade because of the further optimal initial stability. Sometimes you did the OneGuide surgery and the too high the torque of the initial stability. At the time, you can remove the fixture and more widening of the drill holes. And the engine driven is fixture placement about 80%. After then, the hand wrench with the final positioning and the hexa positioning and the final depth control of the fixture. Yeah, this is a hand wrench with the final
The
positioning.
stability is quite good.
Yeah, even though the more wide drilling, but the initial stability is very good. So the good fixation, initial stability of the second molar area, and the final the drill is the fixture size is 5.6.
Placement was done. As I said, in the left side, I will place implant after vertical reduction osteotomy. So I will remove the template.
Yes. The Dr. Kim has the installation of the right side, but the left side we drilled the drill holes, but he wants to do a vertical reduction for the inter-arch distance because of the left molar area is the vertical dimension is very low because of inter-arch distance. He planned before the implant placement the reduction of the alveolar bone, and so he removed the anchor pins and removed the surgical template. The counterclockwise of the anchor screw and the remove of the anchor screw on right side. Dr. Kim removed the anchor screws for the remove of the surgical template, OneGuide template.
Okay.
Yeah, he removed the OneGuide template.
Implant placement was done.
Yeah, Dr. Kim already installation of the right side of the implant, 5 implants. After then,
Now I will extract these 2 premolars, and then vertical reduction osteotomy will be done.
now he will plan to the extraction of the remaining 2 premolars.
속 짚어주세요. 여보세요?
He removed the remaining 2 premolars
어때요?
with forceps.
네, 뽑았어요.
Yeah, the patient has slight painful, so he do the more local anesthetics.
마취 하나도 안 된 것처럼 아프세요?
I think that he has the more periodontal
많이 아파요, 지금도.
chronic periodontitis and with some kind of the inflammation. So sometimes the extraction of the teeth is sometimes slightly painful. So Dr. Kim did the more local
So
anesthetics.
now I open the flap for vertical reduction.
Dr. Kim has incision of the left side for the reduction of the alveolar bone ridge. And Dr. Kim has incision after then the elevation of the mucoperiostal flap for the alveolar bone reduction, vertical
I
reduction.
will do one more block anesthesia.
Yeah, maybe the patient has slightly painful, so he did one more inferior alveolar double block for the patient, the comports. Yeah. He elevated the mucoperiostal flap. After then, you can see the alveolar ridge and the.
지금 괜찮으세요? 네. 오른쪽으로 돌려주시고.
and the removal of the extraction area and the
You can see the highly positioned extrusion of this. So I will grind. This is the first from the hip.
yeah, he did the reduction of the osteotomy for the optimal inter-arch distance for the final processes. And he did the vulcanite bar with the reduction of the osteotomy and the left side.
지금도 많이 아프세요? 먼저.
Removal of the alveolar bone with the bone longer and the collecting of the autogenous bones. This is bone longer and the removal of the overlying bones. And the grinding of the alveolar bone and the reduction and osteotomy for the final processes. I think that Dr. Kim has already the drilling about 11.5 the length of the drill, but after then the reduction of the alveolar bones and for the final processes. And because of the collapse of the vertical dimension and the left side is interocclusal distance is inter-arch distance is very low, and because of the further optimal space for the final processes. Maybe the patient has the multiple tooth remaining with the chronic periodontitis, and there are some inflammation of the around the tooth. Maybe sometimes during the extraction, even though we did the multiple injection of the local anesthetics, but the patient has a small, slight painful. Because of the slight inflammation and with maybe the more bleeding, maybe sometimes the more massive bleeding at the time. Usually the is irrigation with the saline, and the local anesthetics is slightly recovered, and the patient is slightly painful, and the reduction of the alveolar ridge with the vulcanite bar. And you can see the bleeding from the mandible and alveolar medullary positions. And maybe before the extraction, the teeth has the chronic periodontitis with inflammation. Maybe the bleeding is slightly.
Yeah, vertical reduction was done.
Dr. Kim did the vertical reduction of the left side, especially premolar area.
Okay. I will do final drilling. I will do drilling in post premolar area, left side. And this is OneGuide kit. Drill 2.2 drill from OneGuide kit.
Yeah, this is OneGuide 2.2 drill for the positioning of the left premolar areas.
And then F3.5.
3.5, the 3.5 OneGuide drill, and but for 10, the length is 10. The first premolar area.
This is 4.0 by 10.
Yeah, this is the 4.0. The length is drill length is 10 millimeters.
And then bone quality is not so good, so I will do underside drilling.
Yeah, Dr. Kim has said the planned fixture is 4.5 millimeter diameter of the fixture. Of the length is 10 millimeter, but he did the undersized drilling of the only the 4.0
This is a 4.5
drilling.
by 10, which is
this is the installation of the fixture with the fixture driver with the engine drill.
so I will do depth control.
Yeah, depth control with the wrench, handle wrench, and the positioning of the implants.
Implant placement was done in the post premolar area, and then here the drilling was done in molar area. I will check the drilling depth again.
Yeah, he checked the drilling depth.
3.5 in 6, around 7 in
Second molar area.
7.
Yeah, Dr. Kim already drilling with the OneGuide templates about 11.5 length of the drilling, but after then the bone reduction, he checked the drilling depths with the depth gauge. The first molar area is 8.5 length and the fixture, and the second molar area is 7 millimeter. Yeah, 7 millimeter, because of the he did the more length. More longer the drilling, but after the bone reduction, he checked the drilling depths with the depth gauge after the installation of the more short implants. So the first molar area is 8.5 length of the implant, and the second molar area is of the 7 millimeter implant. And the final positioning with the hand wrench.
Okay. If was placed here in 6, 6, 5, 7.
The second molar area is the length. The implant fixture is the length is 7 millimeter implant. And the final positioning with the hand wrench. Yeah.
All implant placement was done, and then I will connect abutment.
Dr. Kim already the placement of the all implants pre-planned. After then, he will connect the abutment.
힐링 abutment 쪽. 왜 이게 7? 왜 7번 할까요? abutment 먼저 시작.
He will connect the abutment for the temporary processes. And this is the healing abutment of the left side. Because of the left side is the positioning is with the using OneGuide templates of the exact position, but depth control is free-handed surgical procedures, so we cannot make the provisional processes. So the Dr. Kim, the left side is connected with the healing abutment. So this area is not for the temporary processes, only the healing abutment. Healing abutment of the left molar areas and connecting.
And here first.
This is temporary processes, provisional restoration.
Both canine implant, I will connect the transfer abutment.
He said the both canine area is the transfer abutment for the placement of the temporary processes. He checked the position of the temporary processes.
당겨줘. 거의 다 되셨어요.
Yeah, he checked the temporary processes, provisional restorations, and he connected the abutment, the left canine area. Dr. Kim connected the temporary processes with the screw.
어디가 아프세요? 한데요. And the right canine.
Now is connect with the right canine area is the abutment. You can see the placement of the temporary processes, provisional restorations, and originally we planned the position, the place.
And both canine area I connected transfer abutment, and then two more abutments will be connected.
Yeah, now the both canine area is application of the abutment. Dr. Kim, can you hear me?
보세요. 오케이. 인젝터.
Yeah, now the
예. 멋있다 좀.
during the surgery, maybe the microphone of the Dr. Kim's is slightly disconnected, so I can't hear the Dr. Kim's sound. I'm so sorry. But he placed the temporary prosthesis and with the placement of the abutment.
And one more abutment.
Oh, now we connect. Can you hear me, Dr. Kim?
Yeah.
Yes. Yes. Now is we connect.
스크류 하나 더 줘.
Yeah, he did the placement of the abutment of the both canine area and right premolar area, and now the try to the positioning
스크류 하나 더 줘.
of the right molar area.
이거나 빨리 줘. 상관없어. 아시고요.
Now the he connecting of the abutment of the right molar area with the hand driver.
Okay. So later I will do tightening and then 물어보세요.
Yeah, you can see the maybe the relatively good positioning of the temporary prosthesis, provisional restorations, and the occlusion with the opposing teeth is very good, and maybe the temporary provisional restoration is good positioning of the we pre-planned the position.
Yeah, because all implants are placed same as my planning, I could connect one-piece type provisional restoration along with abutment like this.
Yeah.
The marginal fitness is good. Beautiful. 아, 보시고요.
So the Dr. Kim verified the positioning of the temporary prosthesis and the pre-planned position, and we did the placement of the implants using the OneGuide template, and the right side the implant is good positioning of the implant. So we pre-planned the provisional restorations is adapt very good, and we can see the you can see the good the adaptation of the provisional restorations and the exact we pre-planned the positioning, and you can see the opposing teeth is occlusion is relatively good, and so the maybe good position of the provisional restorations of the patient. So but left side and drilled with the exact position is with the OneGuide template, but after then the extraction of the premolars and the reduction of the vertical bone of the left side, so the exact positioning of the depths and the is not planned, so he did not connect with the provisional restorations of the left side.
진지백tomy was done.
Yeah, and he did the abundant the reduction alveolar bone reduction. After then, slightly gingiva is removal from the left side, lingual side, and the closure of the primary closure. Did. He trimmed the slightly lingual the gingiva, and after then closure with the sutures. Yeah, he already almost procedures.
As you can see, after grinding the left side, I could secure appropriate space for final crown.
Yeah, he said the left side is interocclusal distance is not so good. He already did the vertical osteotomy of the left remaining alveolar bones, so the for the final the processes, and you can see the provisional restoration and the pre-planned by OneGuide templates and the exact good position of the implants. So you can see the provisional restoration has relatively good occlusion with approach.
Tightening with torque.
And
around 20 to 30 Newton tightening torque is recommended for immediate loading.
Yeah, for the tightening of the screw for the immediate loading, and
also cementation is also important factor to get successful immediate loading. So rigid splitting should be done. So I will use final cement.
Yeah, he wanted to the final cement for the temporary and provisional restorations, and now he torque wrench with the final tightening of the each abutment screws.
Fitness is quite good.
Yeah, you can see the good occlusion between the lower provisional restoration with the upper arch, and he did the good restorations. Yeah, very wonderful surgery and with good live surgery.
I will take a camera and I will have a Q&A session. Thank you.
Yeah, thank you very much. Wonderful live surgery of the Dr. Kim.
Thank you.
Hi, Dr. Kim. Yeah, very wonderful. Yeah, thank you very much for your nice lecture and with the wonderful live surgery.
Thank you.
And yeah, it's very good. And I think that now is COVID-19 is a worldwide pandemic state. Yeah. So how was feeling of such a connected?
So usually I was in other countries for Osstem AIC course, but in this year I could not go, so I missed so many countries and the dentists from other countries.
Yes. During your surgery, and there are so many talks in the live talks. Yeah. So now we have to do a lot of the questions, and now we will do the Q&A sessions.
Yeah.
Yeah, there are one question. maybe I can't the exact pronunciation of the name, but Dr. Kumaro, and they said now you did the maybe the right side, maybe right molar, second molar area is to hide the torque, and then you widening of the drill hole, and maybe he wanted to explain about that.
So usually OneGuide surgical kit was made based on 1 to 2 taper kit. The drilling concept is completely different from normal taper kit. So when using the 1 to 2 taper kit, in the normal bone, the final drill size should be same as planned implant diameter. But soft bone, 1 step undersize drilling. In the hard bone, just like our previous cases, if the initial stroke is greater than 50, so at that time, one size oversized drilling should be done. That's the main concept of 1 to 2 taper kit. So OneGuide kit was designed based on 1 to 2 taper kit. I followed that drilling sequence.
Yeah, I see. Dr. Kim said this is the OneGuide drill system is same as the 1 to 2 drill. And maybe the Osstem implants recommend the 1 to 2 drill sequence is usually the same size is a nominated drilling, and so the normal drill, normal bone at the time we can do but the right side is initial torque is too high. At the time you can widening, and for the 5.0 fixtures, but you did the drill 5.5 drills. I see. And then now is I have some questions because of you did the right side is the OneGuide template, and the left side is for the remaining tooth is removal after the vertical reduction. Sometimes it's very difficult to estimate the bone reduction. How can you plan?
So during using the implant studio for OneGuide system, my technician designed the ideal prosthesis. So based on the prosthetic design, I could decide the amount of bone reduction required to make that prosthesis.
I see. You can see the preformed designing. After then you can estimate. And you did the longer drilling.
In the number 6, in the left post molar area, 11.5, 7, 10. But I placed 8.5 and 7.
Yeah, you are a good surgeon. Your skill is very good because of you drilled already about 11.5 and about 10 millimeters. But after then, you can check the bone reduction, and the drill depth gauge is 8.5 and 7 millimeters of the second molar area. Yeah, very good, wonderful surgery.
Thank you.
Now maybe the final panorama is prepared, so you can see the.
As I planned, place there. But in the left side, I just connect the healing abutment. In the right second molar area, I will connect the healing abutment again. I missed the healing abutment connection. But so by checking the connection, the quality of the provisional restoration connection, we can evaluate the accuracy of OneGuide system. Because of good OneGuide system, I could place implant well. Yeah, you can see in the post-operative final processes, and the provisional restoration is relatively good adaptation and good positioning of the implants, maybe. And there are so many checking the rooms and there are some questions, and Dr. Dankar. It's very difficult to pronunciation of the name, but very nice surgery. And please suggest how to re-verify the vertical dimension after temporary processes. You mean maybe the temporary processes planning? So during this patient has a right side remaining premolar. So based on that remaining premolar, I could evaluate evaluate and the vertical space. So, and also during using this provisional restoration, I will check the TMJ symptom. So if patient is quite good, so I will make a final prosthesis with that
Yes.
re-establish vertical dimension. But patient has some discomfort, I will adjust.
Yeah, I see. You can see the concerning of the
Right.
TMJ
Right.
conditions.
Yeah.
And the other question is Dr. Spade, and how to gauge how much bone to remove to achieve the favorable intercrucial space. Maybe the similar question. Maybe the free hand is very good,
Yeah.
but usually it's very difficult to estimate the how much the.
Usually to use TS3, internal connected type bone level system. So at least 6 millimeter vertical dimension
Yes.
is required. But from the bone, 9 millimeter because of the biology width.
Yes.
3 millimeter biology width and 4 millimeter abutment height and 2 millimeter
Yes.
zirconia or crown prosthetic thickness. So at least from the top of the bone to the top of the crown, we secure 9 millimeter.
Yes.
Yeah. Based on that
Yes.
formula,
Yeah.
I evaluate.
I see. Dr. Kim said that we have the TS system is a bone level implant. So we have to do 3 millimeter for the biologic width.
Yeah. And
After then, abutment space about 4 millimeters.
Right.
And 2 millimeters for the final processes,
Yeah.
Such as the zirconia
Yeah.
and other things.
Yeah.
So you mean the
9 millimeters.
9 millimeters.
That's
Yeah,
my
I
minimum.
think that it's very important.
Yeah.
There are so many doctors' memory about the 9 millimeter, minimum 9 millimeters
Yeah.
for the from bone level to the top
Right.
implant
Exactly.
top. Yeah, I see. Oh, it's good. And there are so many you are wonderful nice surgery, and there are so many wonderful.
Thank you.
And we can now now we close these Q&A sessions, and thank you very much again,
Thank
and
you
for
for your
your
wonderful
wonderful nice surgery and nice temporary processes.
Thank you.
Yeah. Yes. Yeah. Now is I think that Dr. Kim's lecture and live surgery was both outstanding and very wonderful. And I think the response from viewers clearly showed that. And let's take time now. We can do the. And now, next up, the second lecture will be on the subject of the OneCAS-guided transcrestal sinus lift by Professor Changju Park. And let's welcome Dr. Professor Park to this session.
Hello, dear colleagues and friends. I'm Professor Park. I'm very honored to have an opportunity to meet Osstem users and Osstem lovers from all over the world in Osstem online meeting. Today, I'd like to talk about OneCAS-guided transcrestal sinus lift. In this lecture, we will discuss about sinus lift surgery, transcrestal, and lateral, particularly transcrestal hydraulic sinus lift, and current digital trends. Then we will explore OneCAS system in depth with case reviews. A short take-home message will be presented in the end. Sinus lift surgery is divided into transcrestal approach and lateral approach. In transcrestal approach, osteotomy is performed on the inferior wall of maxillary sinus or alveolar bone for sinus lift surgery. Meanwhile, in lateral approach, osteotomy is performed on the lateral wall of maxillary sinus for sinus lift surgery. This is a table showing the comparison between and for cases requiring a single implant placement. Its advantage is it will result in less post-operative complications and less patient discomfort because it is a less invasive technique compared to lateral approach. But its disadvantage is that it is a blind technique, meaning that we cannot actually see the sinus membrane during the surgery. The osteotomy technique is a prototype of transcrestal sinus lift. Osteotomes with varying sizes are used with the mallet and tapped with the mallet to infracture the sinus floor with bone grafting material. Yes, it is a prototype, but I know that it is still commonly and widely used even now. transcrestal hydraulic sinus lift is based on Pascal's principle. If you grab a water-filled bouncy ball, on equal area, transcrestal hydraulic sinus lift uses a saline as a lifting medium. In a confined space filled with saline, a pressure is being given from a syringe. It is transmitting to the sinus membrane for hydraulic separation and lifting of the sinus membrane. Much more safer. There have been a lot of modifications and variations of transcrestal hydraulic sinus lift from the early 2010s. As one of Osstem's Hyosyn's best-selling kits, a decade has passed since the introduction of casket or crystal approach sinus kit in implant market. Casket is equipped with perforation-free drills with round edge and flat bottom, and its use is strictly controlled by the connection of various stoppers. And hydraulic membrane lifter or hydraulic lifter is used for hydraulic separation and lifting of the sinus membrane. The response of sinus membrane of mechanical lift by osteotomes is a cylindrical sinus membrane elevation with restricted base. In contrast, the response of sinus membrane of hydraulic lift by casket, dome-like elevation of sinus membrane with wide base, meaning more osteogenic cells can be induced into the bone grafting material around the implant fixture. By a direct sinus endoscopy, courtesy of Dr. Zhou, much higher and much wider elevation of sinus membrane is observed while the saline moves in and out of the drilling hole. Dome-like sinus membrane elevation with wide base. Digital revolution is recent major trend. In implant dentistry, data preparation by con-beam CT taking, and intraoral scanning, virtual planning by various softwares, 3D printing of surgical template, and surgery and immediate provisionalization, or digitally guided implant surgery is enjoying its unstoppable rise in popularity. Yes, digital revolution is changing the ways we live and we work. Velga et al. Showed any degree of guidance, pilot guided, partial guide, and full guide yields better results than freehand surgery. And increasing the level of guidance from pilot guide, partial guide to full guide increases accuracy in their study. As you already saw through Dr. Kim's excellent live demonstration, Osstem Hyoscine introduced its own digitally guided implant surgery system called as OneGuide. OneCAS-guided incorporates the excellent features of casket into OneGuide system. Virtual planning by Implant Studio. The accurate measurement of RBH, or residual bone height, the lowest and the highest according to the simulated implant fixture. These delicate measurements of RBH will fully guide your transcrestal hydraulic sinus lift. By casket, surgeon-dependent drilling is performed in tentative position and depth. However, by OneCAS-guided, template-guided drilling is performed in predetermined position and depth. As you see, drilling depth is strictly controlled by OneCAS template and various stoppers. In other words, it means that OneCAS system will be more suitable for implant beginners because it is much simpler and safer. I will explain in detail the procedural steps of OneCAS system. In a case of 4 millimeter RBH or residual bone height for Osstem TS3, 5.0 by 8.5 millimeter with normal bone density. You don't have to pay attention to the thickness of soft tissue. 3 millimeter in this case during the surgery, because it is already reflected to the thickness of OneCAS template. The only factor you should consider is the residual bone height, 4 millimeter in this case, during the surgery. Tissue punch is used to punch out the gingival plaque for flat lid surgery as a digitally guided implant surgery. It's one of major merits of digital surgery. Then 2.2 twist drill is used up to 1 millimeter below the sinus floor. As you see, drilling depth is strictly controlled by OneCAS template and various stoppers on 2.2 twist drill. After 2.2 twist drill is used, enlarge the hole by serial application of OneCAS drills. OneCAS drills have the same design with cast drills with round edge and flat bottomed. It is very safe, even used in 800 RPM. And please check the drilling depth and position and the angulation is strictly controlled by OneCAS template and stoppers connected on OneCAS drill. 3.1. In 800 RPM. And the finer drill connected with the same stopper to keep the drilling depth constant up to 1 millimeter below the sinus membrane to enlarge the hole. This is a finer drill, OneCAS 4.1 drill. Then the next step is approaching the sinus floor. Use the same OneCAS drill, 4.1, but drilling depth is increased by decreasing the stopper height. Again, drilling depth is increased by connection of shorter stopper. In 800 RPM. This drilling is also strictly controlled by OneCAS template and the connection of stopper. In this case, the sinus floor is not going away. It's checked by a flat tip depth gauge to check the bottom and the exposure of sinus membrane. The sinus floor is not going away, so the same finer drill is used by increasing the drilling depth by decreasing the stopper height 1 more millimeter to the sinus floor. In 800 RPM, the sinus membrane is exposed and sinus floor is gone away. As I showed you, in every step to approach the sinus floor, not to enlarge the hole, the drilling site should be checked by a flat tip depth gauge. The exposure of sinus membrane is confirmed. Then the OneCAS template is removed out of the patient mouth. Hydraulic lifter is connected by a syringe filled with saline, is ready to use. The adaptation of membrane lifter or hydraulic lifter seal the drilling hole, and the saline is pushed in to separate and lift the sinus membrane. And the saline is pulled out. The presence of the blood in the tubing is very important because it is indicating the sinus membrane is separated. The saline is pushed in, pulled out, and totally pushed in. The separation and lifting of sinus membrane is done. OneCAS bone carrier is inserted into the drilling hole. And bone graft material is pushed in by the use of bone condenser. Little by little, step by step, and in drips and drops. This is a very important step, removing all the saline from below the lifted sinus membrane to minimize the dispersion of grafted material. It will help the condensation of the grafted material around the implant fixture apex. The OneCAS template is applied again, and the implant fixture is placed, guided by OneCAS template. The delicate control of final implant position is done by hand-driven fixture driver and torque wrench. Implant placement is done, and OneCAS template is removed out of the patient mouth. Healing abutment is hand tightened because of the good primary stability in maxillary posterior area. Transcrestal hydraulic sinus lift and simultaneous implant placement is all done. OneCAS system really works, particularly in sloped sinus flower. Virtual planning on merged conveam CT data will give the implant practitioner two numbers, A and B. They are the number of residual bone height, A, the lowest, and B, the highest, according to the simulated implant fixture. Particularly in sloped sinus flower, the number A, or the lowest residual bone height, determines the initial drilling depth for partial perforation of the sinus flower. Through this small hole, the sinus membrane is lifted and separated. After separation and lift of the sinus membrane, the final drilling depth determined by number B. B means the highest RBH, or residual bone height, to totally grind off the remaining sinus flower. And hydraulic lifting is done by hydraulic lifter for wider and higher elevation of sinus membrane before grafting. Now it's a time to review cases. This is a very interesting case. 57-year-old male patient with no smoking habit complained of the tooth pain of tooth number 26. In his initial panoramic view, you can see the sinus polyp on the apex of tooth number 26. Suspected diagnosis of odontogenic rhinosinusitis. The causative tooth is removed, and even 4 months after the tooth extraction, the sinus polyp was not gone, just showing a small decrease in its size. The patient was referred to an ENT specialist, and the answer was, in OMUCT, the ostium of the patient's left maxillary sinus was opened and patent. Sinus lift surgery was not contraindicated. For much accurate and careful instrumentation by OneCAS kit, I plan the digitally guided implant surgery with transcrestal hydraulic sinus lift. Virtual planning was done, and as I told you, 2 numbers of RBH, or remaining bone height, below the sinus. The lowest and the highest were given to us, and the 3D printing of template was done, and this is immediate post-op panoramic view. No sinus membrane damage or perforation. Pre-op cone-beam CTs, you can see the sinus polyp, and these are immediate post-op cone-beam CT views. Implant fixture was placed with bone grafting, no damage on the sinus polyp. It was just push it into the sinus floor. Very careful, accurate, and safer instrumentation by OneCAS kit. Panoramic view after the delivery of final restoration. You can check the newly regenerated sinus floor after grafting below the sinus polyp. You know, this was a table I showed you showing the comparison between transcrestal and lateral approach. But how about the cases with RBH or residual bone height less than 5 millimeters? Or the cases for multiple implants placement? Can they be dealt with by transcrestal sinus lift? Yes, I think it's possible by OneCAS kit. In these complicated cases requiring 4 implants and 2 implants needing sinus lift, because the remaining bone height, or RBH, on the first maxillary molar was estimated to be 3 millimeters, and the RBH on the second molar area was measured 2 millimeters. But this patient had a flat sinus floor. The transcrestal hydraulic sinus lift by OneCAS kit was tried. Please check. 2 multiple implants in residual bone height lower than 5 millimeters. It was the absolute indication of lateral approach before the introduction of OneCAS. Virtual planning was done, and the OneCAS template was 3D printed. This was the first OneCAS live demo held in 2018 Osstem Seoul meeting. As you see, the strict depth control, drilling depth control, is obtained by the OneCAS template, and stoppers on the drill. The sinus flower in the first maxillary molar area is gone, checked by a flat-tipped depth gauge. The hydraulic lifter is adapted and seal the hole, and saline is pushed in and pulled out, and you check the presence of blood in the tubing, meaning that the separation of sinus membrane. Then, OneCAS bone carrier was inserted into the hole, and very quick insertion of bone graft material is being done, as you see. Very quick filling is possible by the use of bone carrier and bone condenser. Even faster than the use of syringe-type bone graft material. Then this is a very critical step I showed you before, to remove all the saline from below the sinus membrane to minimize the dispersion of the grafting material. Then, OneCAS template is readapted. A fixture as Osstem's new surface, soy, is being inserted by guidance of OneCAS template. Then, the drilling, lifting, grafting, and implant placement is being done in the maxillary second molar area as a totally different site, one by one. These two sites, the maxillary first molar area and the maxillary second molar area, are considered to be totally different sites. Drilling, lifting, grafting, and implant placement in the first maxillary molar area, and drilling, lifting, grafting, and implant placement in the second maxillary molar area. Immediate post-op panoramic view, cone beam CTs. The first premolar implant, the second premolar implant, and the first molar implant, and the second molar missing area implant. Good position with satisfactory bone grafting by OneCAS kit. In complicated case like this, requiring multiple implants in RPH lower than 5 mm, OneCAS can be one of solutions. Panoramic view after the delivery of the final restoration. Take-home messages. Hydraulic transcrestal sinus lift is technique sensitive because we cannot actually see the sinus membrane. It can be more technique sensitive, but clinically proven, patient, and surgeon-friendly technique to reflect accumulating scientific evidences. Osstem HigherSense OneCAS system can help the implant practitioners perform the transcrestal sinus lift in a simpler, quicker, and safer way. Recently, I watched a Turkish film, Ayla, based on a true story during the Korean War. It was very touching, and I realized the long and everlasting relationship between Turkey and Korea. Teşekkür ederim, and Osstem users and Osstem lovers from all over the world. Thank you for watching.
Hi, Professor Park. Nice to meet you. How about the feeling of this online meeting?
Professor Kim, thank you for your comments. And I have visited Turkey twice for lecture. Therefore, Turkey is very special to me. And unfortunately, 2020 Osstem World Meeting in Turkey is delayed.
Yes.
But I miss all of you Turkish implant practitioners, and please stay well and keep safe during this hard season of COVID-19.
Yes. Yeah. I was so sorry because of the postpone of the World Osstem meeting in Turkey, Istanbul.
Absolutely.
Yeah. I think that our viewers might have many questions. They would like to ask Professor Park, as I have. Let's listen to a few of them now, and let's move to the Q&A sessions.
Thank you.
There are many questions, and the first question is how much lift is expected by transcrestal approach, including hydraulic method?
It's a very good question. Previous studies have shown that the amount of sinus lift of mechanical transcrestal sinus lift is ranged from 3 to 6 millimeter. However, the amount of sinus lift of hydraulic method by cascade or one cascade is ranged from 10 to 12 millimeter,
Yes.
much higher. But I think the amount of sinus lift is important, but more important thing is the pattern of the sinus lift. As I showed you, the cylindrical sinus membrane elevation with restricted base is not good for the newborn regeneration. The dome-shaped elevation with wide base obtained by casket or one casket high rolling method, it's much better for bone regeneration after transcrestal sinus lift.
You mean the previously the conventional technique, such as the osteotomy technique? At the time, usually the elevation of the sinus membrane is very low base, but you can see with the casket or one casket and more wide elevation of the sinus membrane.
Definitely,
Yeah,
Professor
yes,
Kim.
yes.
That's
Maybe
right.
the good, results. And the second question is, how do you deal with the membrane perforation during the transcrestal sinus lift? Sometimes, maybe.
Professor Kim, as you know, a main drawback of transcrestal sinus lift is its procedural blindness to the sinus membrane. If you are an experienced implant surgeon, you can see and repair the perforation, change it into by lateral approach.
Yes.
And the application of a collagen membrane. But I know that the transcrestal sinus lift is preferred by general implant practitioners. Therefore, my recommendation to the implant practitioners preferring the transcrestal sinus lift is stopping the procedure and closing the wound. Let the site heal for another 4 to 6 months. Instruct the patients do not blow their nose too hard. And in 4 to 6 months, try the transcrestal sinus lift again.
Yes.
In healed site with healed sinus membrane.
Yeah, I see. You mean actually during the crestal approach, at the time unfortunately the membrane perforation, at the time the crestal approach is as blind technique. So the repair of the perforation is very difficult and sometimes impossible. You have to postpone the operation, or you can switch with the lateral approach.
That's exactly what I said.
Yes, I see. Yeah, you mean the lateral approach is we can see the operation field and we can properly
the sinus membrane
repair of the
directly.
sinus membrane. Yeah, I see. And maybe we don't have enough time. The next question is maybe last question. Which graft materials do you prefer for the transcrestal sinus lift? What kind of materials?
That's a very hard question to answer properly, but I know that there are different availabilities of bone grafting material depending on countries.
Yes.
As for me, I prefer the allograft.
Yes.
Allograft, demineralized or not, is a first choice for bone making.
Yes.
But unless the residual bone height or RBH is good to obtain implant primary stability
Yes.
or too wide, the application of a xenograft, BIOS or Osstem's AS is indicated, and the addition of xenograft to allograft, it's a kind of good combination for bone making and bone maintaining. I think allograft is the first choice, and a xenograft is the next choice for me.
Yeah, I see. You mean there are many countries has different situations. So according to each country's situations, but in Korea, the available of the allogenic bone and the xenogenic, such as the bovine bone. And you mean the bone making is more excellent of the allogenic bone, but space maintained maybe from the xenogenic and the bovine bone.
Yeah, many clinicians already know the volume maintaining effect of a xenograft.
Yes.
Yeah, it is definitely needed even in sinus lift surgery.
Yes. Thank you very much.
Thank you very much.
I'm so sorry that we don't have enough time. So thank you very much, Professor Park, and for that excellent lecture and your detailed answers. Now, as mentioned earlier, we have the special program prepared for our viewers today. We are going to go live with Dr. Özgür Bultan in Turkey, and with the video conference call. I will pick it back up after the conference call. First try of the video conference call, but there is some technical problems, so we have to do reopening of the Turkey from the Dr. Bultan. Yeah, I'm so sorry. Please wait for the connecting of the delay. Yeah, I'm so sorry. This is technical problems. I'm so sorry. I'm so sorry. We apologize again for not being able to broadcast smoothly. We prepared the first try of the video conference connection between Korea and Turkey. But there is some technical problems, so the video connection is good, but the voice connection is just some problems. So we have to quit this Osstem meeting online now. So we prepared more carefully. After that, we will meet you again next Osstem meeting online. Thank you very much.